Good evening to everybody, and thank you very much for inviting me to be a part of this session along with Dr. Anand Zak and Dr. Binila. It's an honor to be able to share some experience from my time and my experience in Chinchpada. So. I trained in medicine in CMC Vellore from 2018 to 2021, and since then, for the last 4 years, I've been working in a mission hospital in northwest Maharashtra in a place called Chinchpada, in Chinchpada Christian Hospital. So these are just few slides that I would like to just put forward to share some perspectives from our hospital, especially as we deal with neurotoxic snakebite patients in a rural setting, in a place where all the resources that are usually present in a tertiary or quaternary centers are not available. So, just few things that I would like to put forward is that most of our bites that we have seen in Chinchpada are mostly viperoid bites or cobra bites. We have seen quite a number of crate bites as well, but we feel that they are slightly less common compared to the others. One very important uh, perspective that we have towards approaching every snakebite patient is that we consider every snakebite patient to be a VIP. By VIP, what I mean is that this disease or this tragedy that strikes a person usually is a poor person. And a snake, while a snake or an animal cannot choose between the rich and the poor, but we ask ourselves that does it really have a choice? Because when the snake is only surrounded by farmers or laborers or daily wage workers, then it really doesn't have a choice. It will invariably be a poor person who will come to you with a snake bite. It is very it's snake bites in urban areas or um, uh, areas where there are buildings and such. Those areas we don't see much of patients with snake bites. So knowing that actually sets the tone and it sets the pitch by which from where we start. It gives us a very important frame of reference as to which kind of people are we dealing with, which kind of people need our care and our attention and essential medications. So we should approach every snakebite patient as if that person is a very important person, highly esteemed in our eyes, in God's eyes, and he should be approached with that sense of necessity, urgency, and context. So this is just, these perspectives and these principles have helped us and has guided us, served as a guiding light for us to treat our snakebite patients in a particular through a different perspective, and that's how we see our snakebite patients. So going into the physical details or the medical details about it. So snakebite management is uh, is these three things. Basically, it is simple. It is meaning it is fairly simple. It's not very complex. It's not very complicated. Few things here and there. When they are done in the right time, they are very very important. It is critical because we cannot lose time in managing a snakebite patients. Time is of essence, and it is definitely it comes as it is very very critical to manage them at the right time with the right resources. And the beautiful thing about snakebite is that it's a very very rewarding diagnosis and disease to manage. So often the improvement, when there is an improvement and when the right medications and right interventions have been put in place, it's a very rewarding experience. It is short time. It's not like a chronic illness goes on for a very long time, but it is something which happens, it strikes suddenly, and then with right intervention, there is very good outcome that we can reap. Crate bites are one of the more merciful bites among the others with lesser complications. It is purely neurotoxic, so we don't see any local reaction. We do not see any myotoxic or hemotoxic complications that we see with other snakes. But the only problem with snake bite is that with crate bite is that it can be very quietly deceptive. It can be misleading. It can be hard to diagnose, especially because crate bites are painless bites. So there may often be a history. There may often be no history snake bite of any bite at all. There won't be any fang marks to help us guide in our management. So what we need in crate bite is a very high index of suspicion. And often we have to remember that they may present with any unexplained pain abdomen in a patient, or any unexplained vomiting, or an unexplained type 2 respiratory failure, or a person who has been found unconscious should be a person who for whom we should be considering a possibility of a snake crate envenomation. So, what we do here in Chinchpada is that we try to stress on early identification of the snake as much as possible, as fast as possible. So, we have to do two things. We have to identify the snake, and we have to, which we can identify through showing Google images to the patient's relatives of the patient. Sometimes they bring the dead snake, which is very welcome, and we can identify the snake then and there itself, and we can rule out non-venomous snakes at the very outset. An important thing is we look for envenomation, definite signs of envenomation, which becomes a definite indication to start urgent and immediate anti-snake venom. Time means CO2. It's like how we say time means muscle for a person with a myocardial infarction, or certain golden periods that are there from door to needle time in stroke or MI. Important thing about crate bite is time is CO2. So the longer the time the patient takes to reach to a hospital and to be administered anti-snake venom, the longer is the time when the person, we can imagine CO2 being built up, and the person's CO2 is rising and the pH is dropping, and the person will definitely have signs of acute type 2 respiratory failure. And important thing about snake crate bite is in a rural setting, we don't necessarily have to have an ABG machine, and ABG need not really guide us. Of an excellent clinical examination and identification of markers of type 2 respiratory failure, where we look at persons a high respiratory rate, rapid shallow breathing, drowsiness, fall in sensorium, and development of signs like flapping tremors or asterixis. These classical clinical signs are enough to direct the further line of management for a person with a scrape bite or a snake envenomation. So these are just, I'll just quickly go through these slides. These are some indications that we use to intubate a patient. So any person who's a low sensorium, Jesus of 7 or below, somebody who has rapid shallow breathing, has flaps, poor neck holding, and a progressive element quadriparesis will be a person who will require an urgent airway management. We will intubate that patient and put the patient on mechanical ventilator. So it is a clinical decision. It is subjective, but we advocate an early intubation or an early airway management for a person with crate bite, because we know that once they are in type 2 respiratory failure, mechanical ventilation is the way to go. One very important principle that Dr. Anand Zak and Dr. Binila have already laid out are that we know that Bungaro toxins, or the venom toxins from crate, they irreversibly bind to the presynaptic vesicles at the neuromuscular junction. So the ASV is actually only going to neutralize the unbound toxin. Whatever binding has already happened, the ASV is not going to do anything to that. So what is important in a crate bite patient is we manage the airway, and we prioritize. So sometimes we may have to prioritize intubation and mechanical ventilation over ASV administration, because there's only so much that ASV can do in crate bite, because it does nothing to the bound toxins which are already attached to the presynaptic receptors. So these are just few slides that I have put on what we do as a sedation protocol in our hospital. So in Chinchpada, we advocate a light sedation with a combination of sedative drug and an opioid analgesic combination for almost all our mechanical ventilated patients. That actually holds true for nearly any critical illness and any patient who is requiring ventilatory management. All of these patients should be receiving a light sedation. Uh, and we know that it is very beneficial, because the patient will fight the ventilator. and the whole experience, or the person, the person fighting the ventilator, then possibility of self extubation, and then again re-intubating and already intubated, previously intubated patient, the whole thing, the chance of a peri-intubation cardiac arrest, all these complications can be avoided and they can be at bay if we can achieve a nice plane of sedation where the person is patient is calm, and he is not very agitated and very restless, and the whole experience can be a very less traumatic experience, not only for the patients but also for the caretakers, the ICU staff, and the doctors, if there is good analgesia. So we don't want to knock the patient out so that we cannot assess his or her sensorium and neurological status, but we just want a light sedation in which we can examine the patient's sensorium and recovery of his neurological functions. All of that can still be done when the person has a good amount of sedation and analgesia. So some centers, we understand, may not have morphine, but an alternative for those opioids can be fentanyl infusions. Nalbuphine is available in some places, or I would say at least some opioid and a benzodiazepine infusion like midazolam infusion can be put for our patients. We really feel it would be unethical to just leave a patient without any analgesia or sedation. Some These are some cases that I was thinking. Some places where sedation and analgesia may not be wise. So that is like it can, if there's a person if there's a patient who's got a very low sensorium and who has got some focal deficits, or even without focal deficit has severe encephalopathy which cannot be explained by CO2 narcosis alone. In such a patient, we would like to see whether the patient is waking up, is moving his limbs. So we may hold sedation in such patients. Also, are we suspecting any other venom-induced complications in the brain? Are there any infarcts or bleed? Has there been a delay in the patient's presentation in which there is a possibility of anoxic injury to the brain? In such patients, if the patient is not responsive, not waking up at all, is probably 2T by sensorium or 3 by 15 sensorium, then sedation and analgesia is probably futile and is probably best avoided. Also, if the person has got multi-organ dysfunction syndrome, is in shock, has got progressive renal injury, which is seen in viper bites, in such patients, I would probably not give morphine, because morphine will build up and we may have to give smaller doses in such patients, especially because morphine excretion is going to be low in patients who are oligoanuric, and a progressive uremia is also going to add on to low sensorium. So in patients who are shocky, who are oliguric, who have acute kidney injury, in such patients, we may want to avoid a lot of sedation and analgesia. But otherwise, in any other patient, in almost all neurotoxic envenomation patients, we would like to give sedation with morphine and midazolam. So this is our protocol. The drugs can be altered. We can choose any other benzodiazepine or any other opioid agent. So this is what we do is that we take 100 ml NS. In that we put 10 mg of morphine and 10 mg of midazolam and make it a total 100 ml NS, and we give it at 10 ml per hour. So this delivers 1 mg of midaz and 1 mg of morphine per hour, and we can keep increasing this dose. There's no ceiling dose to either of the two agents, but most patients we feel they settle at a dose of 5 mg per hour of both midazolam and morphine, which is approximately 50 ml per hour. In the beginning, however, very extremely agitated, restless patients may require higher doses, but soon these patients will definitely settle at much lower doses. And then we see that the whole experience becomes very calm, very quiet. Patients are communicative, they understand, and there would be very low chance of self-extubation and such complications. What we also encourage in our hospital is that we keep in our hospital, being a rural hospital, a tribal community, we tend to keep patients' relatives on bedside, even inside the ICU. And what we have seen is that it helps the relatives to keep on talking to the patients, and we ourselves, the doctors and the nursing staff, we keep talking to our patients while they are on the on the ventilator. So when we talk to them and we encourage them to when we pacify them, we see that they tend to understand. And even these lightly sedated patients, even though they are on the ventilator, they're able to understand, and they will be able to communicate through their eyes and such. So we feel that talking to our patients about not pulling out catheters, not self-extubating, and encouraging to just persist, it actually helps and goes a long way in ensuring that the whole process is a calm one. This is just a few few lines about how we extubate our patients, or what are the indications. So the indications are similar to a patient with any other critical illness who's ready for extubation. And again, I would like to stress that we very, very rarely do ABGs before intubation or before extubation for especially for patients with snake bite, because there's a wealth of clinical information that we can get from our snakebite patients before and after intubation and before and after extubation. So if you just do a good, nice, meticulous, and regular clinical examination, we will have enough data within our reach to be able to be confident to take the endotracheal tube out. So if the sensorium of the patient is adequate, he has at least M5 of GCS and or he has neck holding. If the patient's cough reflex is good, which we notice when we do ET suctioning or a tracheostomy suctioning. If the patient has landed finally on minimum ventilator support, which is when the patient is on SPONT mode, is on probably somewhere around 7 of PEEP and pressure support of around 7. If the patient is not requiring many inotropic supports, probably one inotrope, but not more than one inotropic support. And importantly, where the cause for the intubation has been eliminated. That means ASV has been given, we feel that the toxin has been neutralized when that cause has been eliminated. And if all of the five above are met, we can stop the sedative drugs that we're giving, the morphine mid infusion, maybe around 1 hour prior to extubation. These drugs can be stopped just before extubation also, just 10 minutes before extubation also. It's not going to cause any masking of patient's sensorium. Patients can continue to communicate even when they are on a low dose of benzodiazepines and opioids. I would just like to conclude. These all my slides are not complete in the way that we know sir and ma'am both have spoken in depth about the management of a crate bite, especially when patients are critically ill and otherwise. But these are just few points or some take home points that I would like to share with everyone. So important thing about crate bite or snake or neurotoxic envenomation is that, as with any other snake bite, a very, very prompt ASV administration the moment envenomation has been established. Obviously, the only indication when we give ASV is that when we are absolutely sure that the patient has been envenomated. If there is no envenomation, then we should wait and we should watch and wait, and then only administer the ASV. ASVs are only for patients who have envenomation. So, but that comes with a caveat in crate bites. That is, ASVs will only be able to neutralize whatever remaining pending unbound venom toxins are there in the system, because it causes irreversible damage to the nerve endings, and the neuronal regeneration is going to take a while. So the important thing that we should remember is that we should not delay airway protective measures. That means there should be prompt intubation whenever it is indicated without any delay. Uh, One experience that I remember from having a crate bite patient in Chinchpada was few years ago when we had a patient with a neurotoxic envenomation. We had only 5 ASV vials with us, and we didn't have the required complete set of files we didn't have. And it was a very clear crate bite, and the person was drowsy, he was desaturating. And while we gave the 5 ASV, we had to intubate the patient. And that was the higher priority than finishing off by making sure that we gave 10 vials of ASV. So what we did later was that we didn't even give the remaining other 5 ASV vials because we simply didn't have them. But what we did was intubate the patient, give the patient mechanical ventilation, and 3 days later the patient is been extubated, and the toxin has been neutralized and eliminated from the patient's system. So the important lesson or point to remember there was that between if I were given a choice between ventilation and ASV for a snakebite patient, and the ventilation is person's airway is compromised, then definitely I would prioritize intubating a patient and putting the patient on the ventilator over just giving ASV, because there's only so much that ASV can do in a person with Krait. So that is very, very important for us to remember, that no patient should die or have a cardiac arrest simply because we took time in putting the endotracheal tube in place or securing the patient's airway. And also, one very important thing is we feel that the most important predictor in our experience of outcome is the time lag and the delay, very, very unfortunate delay that some of our patients have experienced in the time between bite and presentation. So this bite to needle time that is there. When the longer it goes, the worse is the patient's prognosis. So we should definitely be able to prioritize or rather work towards preventing snake bites, and more importantly, educating our patients enough that that moment there is a snake bite, the person should be brought immediately to the hospital. So we, like many other rural hospitals, like Shaheed Hospital in Chattisgarh, we are dealing with patients where there is rampant indigenous, tribal, unscientific, native practices. Many of them are detrimental. They cause a lot of delay in patients' presentation, and it causes a lot of waste of essential time. So that is a very, very important predictor. And obviously, when the patient comes, we want to give them ASV as soon as possible and secure their airway. At the end of all this, these are some pictures that I would like to share from our hospital. Um, these are, this was the last patient, an 8-year-old boy with a neurotoxic snake bite, and he came with 30% saturation, almost stuporose. And we promptly intubated him. We gave him the ASV much later when it was around, when it was available. And this smile at the end of it, when he's discharged, makes all our fears and all our sorrows and tears and all our pain, it just goes away. It makes everything all right. Um, this was 2 years ago. This was our one of our Krait Bite patients, Keshri Bai, who was also intubated, requiring mechanical ventilation. And I think these patients who we have in Chinchpada and the kind of patients that we continue to receive in rural hospitals, uh, these patients should they serve, at least for me, they serve as a very important reminder of as to why have I become a health worker. And it also reminds us of the big privilege and honor of being in the sphere of, or being in the vicinity of, these highly esteemed people, who have very hard lives, who work hard, and who fall victims and prey to such unfortunate conditions. And it also reminds us of the important responsibility that we have towards our countrymen. We owe them a lot, and simply to be in their proximity is actually such a huge honor and privilege for us. So it reminds me as to why we have become a doctor, and how important is our role when we deliver health services to these most deserving and the most needy sections of our community. So this is a final image from my slide, and this is Keshri Bai, the lady who was in the previous slides. Her family, them, their meager belongings, them packing it, and after her 4 days of stay, 4 or 5 days of stay in the hospital, them going back and returning to their simple hard life. And it is such a joy, such a privilege and honor to be able to treat each and every snakebite patient, each VIP patient that we have among us. And I think that knowing that, even though as we wrestle with, or even as we sort of discuss and have a discourse over all the nitty-gritties of medical management of snakebite. I think that perspective, the whole perspective of what is the context of a person with an envenomation, and the principles and the ethos behind it. I think those are the important. That is the wealth that we should hold on to with fear and trembling. And yes, so those are some insights from our hospital. And thank you to Shaheed Hospital in Chhattisgarh for giving me this opportunity to share from our lives. And also a lot of thanks to Anand sir and Vinila ma'am to be able to make everything possible. Thank you very much.